I always like to start with this sentence because it is never my intention to convince anyone of anything, but to share my vision and my conclusions so each one can take their own, right? So I think this is the basis of learning, and that's why I always like to start my lectures with this sense. As Dr. Park already said, I'm from Spain. This is Santiago de Compostela on the north of Spain, a really nice city. And I graduated then, and then I moved to Barcelona, where I made all the post-graduation programs that was already said, and also my PhD. And maybe one of the best experiences of my life is having the opportunity to work for 80 years in this incredible hospital in the department of maxillofacial surgery with Dr. Federico Hernandez Alfaro, that probably all you know. And as I already presented, I was also professor on the Department of Oral and Maxillofacial Surgery in Barcelona. And well, I will always like to start by thanking the one who was my mentor and from whom I have learned so much, which is Dr. Hernandez Alfaro. He's responsible for starting to study the role of TMJ in the field of orthodontics and orthodontic surgery. And it was the subject of my doctoral thesis, from which these 4 publications have come, and some of them I will present to you today. Then I'm a very lucky person, and I had the opportunity to meet this fantastic group that the leader is the great and fantastic orthodontics, Dr. Eric Silva. And I have been living here in Brazil for a while already, and I work as a scientific consultant for EC3D company. So to start talking about this topic, I think we should first think about the real meaning of diagnosis. As you may know, diagnosis came from Greek and means true knowledge related to. And cephalometry, it's just the set of measurements and descriptions of the craniofacial structures. And so we should understand that cephalometric diagnosis is not the measurements. Diagnosis is the interpretations we give to those measurements. And that depends a lot, of course, of the level of knowledge of the professional. So we should always invest on continuous learning. I also love this sentence because summarize this way to think. What is not known is not diagnosed, and what has been seen on a few occasions is difficult to diagnose. So diagnosis needs knowledge, and not only a nice over or nice pictures, nice images. They will never be better than the knowledge of the professional. And this is something that already from the beginning of the cephalometric area, from the cephalometric field, already Dr. Salzman in the Special Committee on Radiographic Cephalometry, they state that once cephalometric points decided, the problem of how and what to measure remains, and which is more important, we will still have to interpret its meaning. There is no unanimity about what it means. So once again, the most important thing is the interpretations, is the knowledge that makes the difference between a nice diagnosis or a bad diagnosis. And well, what is the real evolution from two-dimensional diagnosis to three-dimensional diagnosis? We also need to understand that we need to change our vision, and your vision will change. for me, there is no point to use the new technologies and the nice opportunity we have nowadays to use INCISIVES CT scans and only make or introduce the same concepts that we were using for a long time in 2D, because nowadays we have more information, so we have and we need to use all the information that CVCT are giving to us. So it's our responsibility to use all this information to make a more profound diagnosis. And for that, it's very important to understand that we need to train the spatial intelligence. We need to think three-dimensionally, because nowadays we have the opportunity to analyze our patients in a much, in a bigger way, in a wider vision. And well, what is the evolution? As you may know, all of us study bidimensional cephalometry. Next step was the introduce or the opportunity to generate lateral X-rays from DICOM data. This is something already introduced by Dr. Sevidanes in 2009. And of course, we have some advantages of using this kind of approach. The main advantage is the possibility to reorienting the skull in software before generating the lateral X-ray. But we have a lot of drawbacks. We are not using all the information that CVCT can give us. We have overlapping structures because we are just generating a lateral X-ray. Of course, difficulty in identifying and marking the points, the landmarks, impossibility of precise diagnosis of asymmetries, and we will talk about that a lot, and impossibility to diagnose three-dimensionally the position and the condylar health. So the next step would be what most of the people know as three-dimensional cephalometry. That is the use of all the data of the three-dimensional data of that CVCT and the reconstruction of the skull, but using the same measurements we already perform bidimensional. So it's not a really change of vision. It's only the application of those bidimensional ideas on a three-dimensional skull. So, of course, have some advantages. The possibility of visualizing and marking the points in the three multi-planar reconstruction views. So the marking the landmarks is better, but we have limitations. We need to reassess the clinical normative values for if they're fulfilling 3D. It does not relate aspects such as condylar position in the results and absence of new possibilities that we can perform in silico. So we like to talk about three-dimensional craniocephalometric diagnosis, because we are going to look our patient, our virtual patient, in a wider way. We are going to try to make an interrelation between some craniometric measurements, position TMG, TMJ, health of TMJ, and different vision when we are analyzing asymmetries. So we don't like to talk about cephalometry only, because we are introducing another kind of measurements being more craniometric than cephalometric. Our protocol is known as ESQUERDO, and is composed by different parts that we are going to see and to analyze today. So I use an example. I use a real patient we had, and I made the different approaches that we have today. So what is the difference between made only a 3D cephalometry or a 2D cephalometric versus introducing some craniometric measurements and different points of view? Well, we can, as I said, we can perform a lateral X-ray or a frontal X-ray from the CBCT data. And we, as you already know, have the opportunity today to do all those measurements virtually, and we can have all the normative values that we already know. We can do that in the frontal view also. Next step will be to perform 3D cephalometry. As I said, the main advantages is that I can mark the points, visualizing them in the free multiplanar reconstruction of my CBCT. But it's not a change of the vision. We are using exactly the same measurements we already use by dimensioning. So we are not using all the information that the CBCT scan together with the clinical photos can give us to understand better what is happening to our patient. So in our vision, we can talk about the natural position, natural head position for a day, but summarizing, I just want to share with you that we use our protocol we made in maximum intercuspidation, and you will understand why we use maximum intercuspidation position. So, and natural head position for make all the analysis three-dimensional. So we always check the intraoral photos together with the CBCT to really know if our CBCT was made correctly, exactly the same position of maximum intercuspidation that the patient has. We see that from the outside, from the internal part, and we check that also in the sagittal cuts of incisives and molars to really check that our CBCT scan was made in the desired position we want. Then, as I said, we use natural head position of the patient to make all the analysis, because for us it's very important to have a real understanding of what is happening to our patient in his natural head position. So here we are looking at the frontal and the profile morphological analysis together with the soft tissue reconstruction. And we always check that this position match with the clinical reality of our patient. Then we move to the craniometric analysis of the mandible and TMJ. And this is one of the most important parts of our protocol. As you will see in this lecture, for us it's very important to analyze the position of the TMJ and to make a better understanding of what is happening in our patient in terms of asymmetries. So look at this patient, at this example. We made a measurement of the RAMUS and the body, right side and left side, and we obtained linear difference between right side and left side of 4.3 millimeters. So look at the mental depogoning of that patient. The patient has not a deviation of the mandible. So here we need to start thinking about what is happening in this patient that having a difference between right side and left side of 4.3 millimeters, the patient has not an asymmetry or a deviation of the mandible. So we start with the first point of compensation. And as you will see later on, we start to defining this kind of patients as compensated asymmetrical patient. If you see here, the height of the fossa or the articular fossa between right side and left side, it's almost 3 millimeter in difference. And what that means, it means that even the patient having a difference of 4.3 millimeters between the right side and the left side, she has not a deviation of the mandible because she has a compensation in the height of the articular fossa. We are also starting to look at our TMJ, and we see that this condyle is already with a degenerative process. Then we move to other kind of measurements also related to the mandibular ramus. We define as frontal angulation of the mandibular ramus. So we see the difference between the point gonium and condylium respect to the mid-sagittal plane. And this measurement is very important, especially in patients that undergo orthodontic surgery, because as you know, one of the worst situations is to produce a medial lateral torque of the ramus during the surgery in terms of probability or risk of condylar resorption. So we look at the angulation between the ramus between the right side and left side, and also the distance from that point to the mid-sagittal plane. Then we also analyze the position in anteroposterior position. As you see here, we have another point of compensation of that asymmetry that the patient presents. You can see here we have a 90.3 millimeters versus 11.3 millimeters. Remember that the patient has a 4.3 millimeters difference between the right side and the left side with no mandibular deviation. And she has no mandibular deviation because she has a craniofacial compensations. One of them is the height of the fossa. Another one in this patient, in this specific patient, is the anteroposterior position of the TMJ related to the coronal plane. Of course, for us, temporomandibular joint analysis is one of the most important things of the protocol in terms of providing the patient for treatment that produces stability in the long term. So imagine if I perform a rehabilitation, orthodontic rehabilitation, prosthetic rehabilitation on a patient that presents already a degenerative process on the left condyle, and imagine if I don't see that at the beginning of my planning, it's impossible to obtain stability. That's why we think that it's mandatory to include the TMJ analysis on our protocol for orthodontics, for prosthodontics, or for all diagnoses that we can perform in dentistry, right? So we analyze that in the sagittal view, of course. We analyze the position, we analyze the health of the condyles, also in the coronal view, and we analyze here in the middle cat of the right side and the left side to have a more closer view. But it's not only that we should analyze, we should take in account that in that TMJ, there is also a disc that can influence a lot in our treatments. So in this case, look at the right side, the patient presents this dislocation with reduction, and on the left side, that is the one that presents degenerative process, the patient presents this dislocation without reduction. And why it's important that? Well, there is a meta-analysis that was published in 2020, in which the first thing I want you to point is that from 1,349 studies, only 18 could be selected due to the criteria. Only those 18 was longitudinal studies. So imagine the quantity of studies that we have relative to TMJ that does not perform, or that does not what was performed with a correct scientific method. Of those 18, they analyze almost 3,200 joints with MRA, and we quantitatively study. But the conclusion is very important for all of us, orthodontists or not, or maxillofacial surgeons. Look at that. The degenerative pathology in TMJ is also something that we all know, was higher prevalence in women, but the prevalence of this pathology in patients with this dislocation with reduction was 35%. But the prevalence of degenerative pathology in patients with this dislocation without reduction was 66%. And this is very important because most of those patients does not present pain. So we cannot only analyze our patient or classify our patients as healthy or not if we don't have the imaging to check what is happening in the TMJ of our patients, because we can have, imagine in 10 patients we have in our office, 6 of them, or between 3 and 6 of them can have a degenerative pathology due to this dislocation. So our treatment cannot be stable enough. So the first question I want to share with you today is condylar position and normal occlusion in the anterior posterior view, I mean in class 1, 2, or 3. Is there a relationship? This is something that most of the people think, that there is no relation between occlusion between condylar position or even TMJ disorders. But take a look on the kind of papers we have. Of course, I have all the respect for the groups that made the effort to perform those papers. I know the difficulty to have a good sample size, etc. It's not. I'm not trying to criticize, but I'm trying to share my conclusions about that. If we take the one by Ikeda that maybe is in this topic, is the one with better methodology, better scientific methodology. They only analyze 24 joints, and they state that the difference between the occlusion and the maximum expedation and the central regulation was less than 0.5, and they only made a CBCT from the TMJ, so they don't know if the patient was in maximum interstitiation or not during the process. But they conclude that we should have a conda in this more or less concentric position, having this anterior, superior, and posterior measurements about 1.5 and 2.5 millimeters in the superior space. But if we if we take now another paper, also I only take papers with CVCT or MRA. If we take this other paper, 90 patients, class 1 with CVCT, look the difference in terms of spaces that they found. They found 2.03 in the anterior space, 2.6 posterior space, 4.1 in G superior space. So what can be happening here to have this difference between one and another papers? They didn't look the occlusal scheme of the patients. They don't know if the patient has posterior prematurities or fulcrum. And as we are going to see, it is already been stated by several authors that the presence of posterior prematurity contacts leads to vertical distraction of the condyle. So for us, this kind of image represents, in a CVCT maximum intercuspidation, represents a vertical distraction of the condyle. So probably most of those patients, the occlusion, the maximum intercuspidation and the centric relation was not the same, with a big difference. So what is happening? If they compare class 1, class 2, also two different groups, they obtain similar results with similar spaces that Ikeda found in their paper. If we compare the papers using, as I said, or CVCT or CVCT together with MRA, we see similar results between class 1, class 2, class 3, with no significant difference and no conclusions or no definitive conclusions. So what is happening here? Also, in this another paper that they use CVCT scans, they found no singular characteristics in the TMJ of the normal occlusion group, because similar results were observed by authors using patients with malocclusion. What they observed also is a non-centralized position of the right and the left side was observed, and I will explain why that can happen. And the largest mediolateral diameter of the mandibular condyle process and the posterior joint space showing significantly difference between the right and the left side. And we will talk about that after, later on, we will talk about this topic. So once again, they did not find significant difference between class 1, class 2, class 3. They only found class 3 as slightly more anterior condyle. And what all this, what is frequently observed findings in these studies? First, decentralization of the condyle. In most of those studies found a condyle that is not concentric, is not centralized on the fossa. They also, almost all of the studies found asymmetry in the condylar position when comparing the right and the left side. And what is also very common that when the condyle is posteriorly positioned, it was associated with higher prevalence of pain. But what do most of those studies have in common until now? They subdivide the malocclusion according to only the sagittal relationship, the vertical pattern, or if they have crossbite or not. They don't study the occlusal scheme of our patients, and I mean if the patient present an unilateral or bilateral fulcrum, etc. That we know from from the 50s that if we have a fulcrum in the posterior part of our mouth, we will have a vertical distraction of the condyle. So normal occlusion is not only the sagittal relation, it's not only if the patient has class 1, class 2, class 3, because we can have a class 1 patient that has a big discrepancy between the maximum intercuspidation and central relation due to prematurities on the posterior area. They classify the patients as asymmetrical or symmetrical only clinically. And as was explaining, we can have patients that are compensated asymmetrical patients. We can have patients with big difference in the height of the fossa. So it's very normal that they found difference between the right and the left side in most of the studies, but they don't explain why. And they don't explain why, because if you don't perform a three-dimensional craniometric analysis, you cannot identify as compensated asymmetrical patients. Because for that, you need to know if the patient has difference in the head of the fossa, if the patient has difference in the angulation of the ramus of the mandible, if the patient has difference in the anterior position of the condyle. So those patients was not identified till now. Most of them use only tomography or only resonance. Most of them are retrospective. So there is a lack also of homogeneity in the definition and classification of the temporomandibular disorders. So now we are in a situation that we need papers that analyze our patients on a wider view and taking into account all these points related to the compensations in the cranium that the patient can have, and also taking into account if the patient has an alteration of the occlusal scheme that are altering the position of the condyle. And now it's much easier for us because now we have images for having that answer. So now we have the responsibility to look for and to try to find those answers. And there is something that all the people that made papers that are in research should know, should understand. If we have an answer that is causality always changes. As you may know, the Simpson paradox that is very, very important for us. It happens when we can reach a conclusion and it's opposite with the same data. And it happens especially when all the possible factors that can have influence are not interrelated. So in the specific area of the TMJ and occlusion, if we are not taking into account all the possible factors, we can have both answers. So if we can have both answers, we don't have a scientific evidence. And unfortunately, it's like that. This paradox was very famous due to a problem that the University of Berkeley has that was accused of discrimination in the admission process based on gender. Well, as you can see in the graph, they admitted a higher percentage of men than women. But that was true. Was the university really discriminating by gender? When the data was analyzed according to the different departments of the university, what they found is that women was applying for departments with less opportunities and most difficult probability to enter. So it was not true that they was discriminated by gender. And this is something that I want you to share also with us, that there is a big difference between opinion and science. Most of the people say, okay, you can see the things, you can, in this case, you can see a 6 or you can see a 9. But if is that situation, we are in the field of opinion. The scientific method came for giving the answer to that and to clarify if what is painted on the floor it's a 6 or a 9. So for having an adequate scientific method, they should give us only one answer. If we have more than one answer, is that we are not in the end, or we don't have the final answer. So I will share with you our hypothesis. Of course, I'm not saying that we have the truth, we have the final conclusion, but I only want to say with you that for you to think about that if it's something that you can apply in your office. We think that there is 2 points that can influence on those positions. That is the occlusal scheme, as I said, and disposition. So as I will explain, when the disposition is not on the correct position, we cannot have a total concentricity of our condyle. So we talk about adaptive therapeutic position. And this is something that is already known, that the condyle position is significantly associated with disc displacement, especially in joints with reducible disc displacement. The condyle in those situations usually is dislocated posteriorly in joints compared with no disc displacement. And this displacement becomes more severe when if the disc goes more anteriorly, the condyle returns to more concentric position. Also, they found more posterior condyles in patients with partial disc dislocation, same thing as I said. Condyles back and up, reduce upper space in patients with dislocation without reduction, and patients with dislocation to the lateral, to the medial, will influence on the position in the coronal cut of our CT. So, once again, condylar position and occlusal scheme is not about class 1, class 2, class 3. It's about what is really happening in the context between the upper in the maxilla and mandible. It's not about only the sagittal relation. I can have a big class 2 with no important interference on the posterior, and it's a case less severe than a class 1 with a big posterior conflict or the presence of prematurities on the posterior side. So it's possible to identify what is happening in the occlusal pattern on the patient with CVCT in maximum decuspidation. That's the question. In other words, it is possible to identify the presence of posterior prematurities, so a significant difference between centric occlusion and centric relation. Let's see and let's analyze some examples. I cannot share with you all the different alterations due to time problems, but I will share with you some examples about that, and we will also share everything on our book about three-dimensional diagnosis. So look, a situation of bilateral fulcrum. The patient has a prematurity both sides. I made all my three-dimensional analysis of the patient, as I said, in maximum decuspidation. So here's the patient in maximum decuspidation clinically, and here's the CVCT scan. That we checked that the CVCT was performed in the same position in maximum decuspidation. We also see that on the sagittal cuts. And let's see what happens on the sagittal cut and the coronal cut of this patient. As you can see, the condyles are positioned downward and backward. And in the coronal cut, they are maintained on a centric position. So indicates a vertical destruction. As we know, since many years ago, there is a result of posterior bilateral fulcrum and a vertical distraction of the condyles. The main difference is that nowadays, we have imaging techniques that allow us to analyze that in a very predictable way, much easier than using a CPI. We have the images to see that. So we have the condyle, backward, downward and backward, downward and backward, and we centralize it on the coronal side. Another sample we define as double bite. This is the patient in maximum expidation position, clinical photos, and look what happened with the condyle that was made exactly on the same position. The condyle is, as you can see clearly, is anteriorly and also downward position. Is another type of alteration of the occlusal pattern. In this case, there is also complex in the posterior area, but the patient, the comfort position patient is forward. However, it's just another evidence of this discrepancy between the maximum cuspidation and central relation. So if we want a stable treatment, we need to analyze this aspect before any full mouth rehabilitation, whether with orthodontics, with prosthesis, with implants. In this situation, the condyle is downward and forward. And as you can see, as the morphology of the fossa is narrower, we can see that on the axial view in the anterior part. When we look at this condyle on the coronal part, we are seeing this condyle closer to the lateral wall, and it's just a matter of anatomy. Look how the fossa is if you look at the patient on an axial view. As we go anteriorly, the fossa is narrower. So we analyze the coronal cut, we'll see the condyle nearer to the lateral wall. Look here again. When the condyle is anteriorly, the fossa is narrower. So when we analyze the coronal cut, we see this area closer to the lateral wall. So once again, we need to think three-dimensionally. Another possibility is what we classify as double bite and postural deviation. It's a very similar situation, but in this case, the patient has a unilateral contact that deviates the mandible. And this is even more important because we need to know if our patient has a postural deviation before to perform any treatment, because we can have a confusion and determine a patient as asymmetrical, and what is really happening is that the patient has a postural deviation. So this is the maximum cuspidation of our patients. You can see in the open bite. And look what happens when we analyze the position on CBCT scan in maximum cuspidation. As I already explained, in this case, the condyle is anteriorly and is with a vertical distraction. And in the other side here, same thing, as is anteriorly, we will see closer to the lateral wall. But in the other side, I also have a alteration. I have a vertical distraction with the condyle positioning centralized on the coronal cut. So look at the three-dimensional reconstruction. Look the difference between point B, pogonium, mentor related to the mid-sagittal plane. We need to understand that this patient has not a real asymmetry of the mandible. What this patient has is a postural deviation of the mandible due to a prematurity on the posterior side, on the right side. So we need mechanics to allow us to correct the posterior conflict, eliminating those interference and correcting the malocclusion, of course. This is a case that was treated by Dr. Erti Silva. where they use all the mechanics of air systems based in mini plates. And what they perform is correct those alterations of the occlusal plane to allow the patient to go to a more centralized position of the mandible. Look the patient in the final position. What is more important? If this situation, this is the situation before and after. But imagine if those contacts has any impact on the condylar position, the correction of the occlusal plane will never give us a final situation of the condyle in a centralized position. So if the condyle was with a vertical distraction due to posterior prematurities, we change by mini plates, we change the posterior occlusal plane, and we correct those interference. We can see that we have a vertical distraction on the initial situation, and we have decentralized condyle on the final situation. So it's clear that those contacts produce a difference, produce an alteration of angular position of the condyle in the fossa. This is the pre and post situation. And the final case I will share with you is unilateral fulcrum with postural deviation. Very similar to the previous case. This is the clinical situation of the patient. So once again, we have a anterior open bite, alteration of the posterior occlusal plane. Look again at the condyles. We have a vertical distraction of the condyle on the right side, and we also have a alteration on the left side. Why? Because the patient presents a unilateral contact that are producing a vertical distraction on the right side and deviation of the mandible. So the deviation that we are seeing on our three-dimensional analysis is due to a unilateral fulcrum that are producing a postural deviation. And we need to understand that before any treatment. So once again, if there is no influence, as many authors say, if there is no influence between the occlusal scheme and the condylar position, it would be impossible to correct the condylar position only by changing the occlusal plane, right? So look what happens. This is the planning that was made for this patient, and now you can see the superimposition I made of the patient. Is a patient also treated by Dr. Ed Silva. We made the superimposition technique that we published together. I published together with Dr. Haas, that you already know, and Dr. Renan Alfaro. So this is what happened with the patient. It was corrected the posterior occlusal plane, and it was produced an anterior rotation of the mandible due to this correction. So it was corrected the anterior open by changing the alteration on the posterior occlusal plane. This is what happened before and after. You can see the anterior rotation of the mandible before a gray and after is red. This is the situation after closing the bite, 4 months and 28 days. But what is more important today for me is to show you how we can change, or we can get a more centralized position of the condyle if we understand what is happening on the contacts on the posterior area, and we correct by our treatment. You can see a more concentric situation. But as I said before, we need to understand that there are two main points that are influencing on this situation. One is the occlusal scheme, but the other one is the position of the disc. So in this case, we achieve adaptive therapeutic position because we have a class 2 dislocation of the disc. So this posterior band of the disc will never allow the condyle to be in a very, very concentric position, but it's a much more stable position than this one on the initial situation. So summarizing all of this, condylar position and malocclusion are not related as much. Most of the authors said, well, it's true when the patient's occlusal skin has not been studied. We don't know if the patient has bilateral fulcrums, unilateral prematurity, occlusal centric relation discrepancy, and we know that class 2 patients may have a great malocclusion when it's currently studied. Most of those patients that we are seeing in class 1, if we study the occlusal skin of those patients have a big discrepancy between maximum intercuspidation central relation. So the patient is not really a class 1 patient. And the next one is orthodontics has no impact on TMJ. True, it's true when the orthodontics that we are performing is not capable of correcting the occlusal plane of the patient. When we don't have the chance, the opportunity to correct by skeletal anchorage this occlusal plane, so we are only aligning teeth. And also it's true when the classification of the temporomandibular disorder is only analyzed or based on symptomatology. As you may know, and here we have a very experienced surgeons. There are many people, many patients with internal problems of the TMJ that has no pain. And there are situations even of this dislocation without sounds. So we cannot trust only on the symptomatology of the patient. And this is something that we know, and just for closing this topic, today we don't have evidence in this area because there are a lot of heterogeneity on the classification. There is no very well performed study related to all those factors that are influencing on the TMJ. Moving forward, we analyze the condylar axial symmetry assessment of our patient, very similar to the one I already present. We want to know what is the relation between the right side and the left side in terms of medial lateral torque. And what's more important, we evaluate the axial condylar angle, which is the angle between the condyles and the mid-sagittal plane on the axial view. Some studies have shown a correlation between a very open angle, very open axial angle, and a higher prevalence of this displacement and degenerative pathology. I summarize for you here the main studies that they use CBCT to have these conclusions. But for me, the most important conclusions is that joints with increased axial angle has higher prevalence of this dislocation and joint degenerative process. So imagine, we already have a CBCT scan of our patient. Let's use it. So if we look at our CBCT and the patient has this situation, maybe we should investigate more and try to ask for MRA to know if there really has this dislocation. And higher angle also was found in patients with osteoarthritis versus healthy patients. What we don't know if is the real reason. We don't know if this axial angle is greater, is more open because they have already this displacement with degeneration, or the fact of having this angle more open have a greater tendency to displace the disc. But what is important is that it's a warning sign of intraarticular problem. So if we already have our CVCT of our patient, we are responsible to analyze all the things that we have. And if we have a warning sign of the interarticular problem, we need to investigate more. Then we evaluate the right and the left condylar volume. This is based on a paper I published in 2019 on the Journal of Mesophaseal Surgery, in which I defined a semi-automated three-dimensional condylar reconstruction, trying to find a way to perform this reconstruction in a more precise and more with more reproducibility than the other techniques that was performed before. In fact, I used the other techniques in other papers. This paper is 2016, and I made the classical techniques for condylar reconstruction. But what I saw that I needed a more reliable reconstruction technique, because we are looking for sometimes for a very few difference between pre and post, or even when we are evaluating the progress of a degeneration or even the progress of hyperplasia. And that's why we developed and we defined the other kind of technique. Why? Because the previously used techniques, even the one that I used to use before, was very operator dependent, usually requires various solver, long processing time, and what is more important, the condyle represents more difficulty than other areas, because the density is lower and it's very close to the articular disc. So we nowadays are able to measure the right and the left volume in a more easy way and identify characteristics of the joint degenerations as ossifieds, flattening, and osteoarthritic signs. And there is consensus on the literature that it's much more easy to identify those kind of alterations if we have a reconstruction than if we only look at one cut or 10 cuts of our CT. Why? Because we can are comparing different cuts between the pre and the post, so we can have confused conclusions. Imagine if it's easier to see the reconstruction or to analyze that only looking at the cuts, as you will see here. It's much more easy to identify alterations of the condylar volume, of course, and also the morphology if we have the opportunity to look at the three-dimensional reconstruction than if we only have the cut, especially when we are comparing the pre and post of our patients. Observe here how the concept that I already explained before of compensated asymmetries manifests itself. Notice the difference in height of the fossa between the left and the right side. Look now that we have a big difference on the height position, the height of the fossa, and the vertical position of the condyle. So sometimes we have a big difference between the right and the left side, but the patient does not present a facial asymmetry due to these kind of compensations. Here again, look at this patient. Look at the height of the fossa on the left side, look the height of the fossa on the right side, and we see the same thing in the three-dimensional reconstruction related to the axial plane. We don't have a big asymmetry, a facial asymmetry, because we have compensations on the cranial base. So what are the real clinical applications of the volumetric condylar reconstruction? The possibility of study condylar hyperplasias and obviously the evolution helps in diagnosis between Wolford type 1 hyperplasia and osteochondromas, I will see. Less invasive surgery planning, also monitoring the evolution of the degenerative process and study pathology that affect the condyle. One of the main differences of our way to reconstruct the condyle is that we are able to analyze the internal losses of structure that the patient can have, as you can see here in this example. We don't analyze only the outer area and generate a solid reconstruction, but we are able to know if the patient has also losses of internal structure. It helps also in different differential diagnosis between type 1 condylar hyperplasia and type 2. As you can see also in this paper, we publish about a minimal invasive intraoral condylectomy. I select 2 of those cases where you can see the difference between a type 1 hyperplasia, which is a hyperplasia that occurs during, not usually during teenagers, but what is important is the morphology is maintained, but the condyle is bigger than the other side, and it's auto-limited. But in class 2 cases, we have a condyle that is bigger, but is also, they have also a different morphology, and usually is on an anterior medial position. So it's very important to define our timing of treatment. So the possibility to have a reconstruction give us a lot of information in terms of taking decisions. We can planify less invasive surgery, of course. Thanks to that, we were able to treat those patients by intraoral approach, as you can see in our paper. So, of course, being much less invasive surgery and much more comfortable for our patients. You can check the publication. I can send to you because due to time problems, we cannot explain everything in detail. Also, we can study monitoring the evolution of the degenerative process. Here's another example. This patient, this exactly the same patient that I was presented, that present degenerative process on the left side. It was performed the clinical treatment with viscous supplementation with hyaluronic acid and interocclusal split. And we can measure exactly the difference in volume to know if the patient is better or is worse. We can also make a superimposition of both. We also use the one that we describe and publish. So here you can see the pre and the post situation. The pre is the blue one and the post is the red one. So we can have the opportunity to evaluate the progress of our patients in a better way. And obviously, thanks to that, we can also check the results of our treatment with an error only of 0.10 millimeters. So we can know exactly what is happening or what happens in our patient in terms of distalization, in terms of anterotation of the mandible, and all those things. And finally, as I said, study pathology that affect TMJ and quantify the structure. As I said, we don't use a solid reconstruction, so we cannot, if there is a loss of a structure internally, as occurs in this patient that present a Langerhans histiocytosis. Let's continue with probably one of the most important aspects that the three-dimensional diagnosis has brought us, is more accurate diagnosis of facial asymmetries. And what aspects should we take into account when we analyze asymmetry? I summarize in 3. First one, size, of course. Probably is the most obvious. If there is difference in size between the right side and the left side, obviously. But the patient also can have an asymmetrical appearance due to morphological difference between the right side and the left side. even when there is no linear difference between both sides. Look at this case. This case, the patient presents a facial appearance of asymmetry. If we analyze him in depth, we can see that the patient has not a big difference between the right and the left side in terms of linear difference. But if we look at the morphology of the patient, there is a big difference on the body of the mandible and the menton area that is producing a appearance of facial asymmetry. And finally, the condylar position, axial, sagittal, and coronal, also, as I already explained, can have an influence on the asymmetry. So of course, we have to try to analyze all and correlate all those measurements to understand what is really happening with this patient. And this is a concept that is also published by this group, where they relate the position of the condyle and the skeletal asymmetry and dental asymmetry. And what they saw is that lateral displacement of the skeletal and dental midline are in relation to the condylar head position. And also when evaluating the asymmetries, those studies confirm also that occlusal characteristics may be related to remodeling of TMJ structures, creating asymmetrical relationship. So, summarizing, I want to share with you our protocol to analyze asymmetries. So the first question is, does the patient have a difference in size between right and left side greater than 2-3 millimeters? Or does he have any facial morphological difference? This is the first question. If no, the patient is symmetrical patient. So despite this, does the patient clinically presents mandibular deviation? Because if the patient has no difference in terms of linear difference and has no morphological difference, if the patient has a mandibular deviation, we should investigate possible postural deviations. Let's move to the other ones. If the answer is yes, the patient is asymmetric, but we need to now answer this other question. The degree of deviation is equivalent to the difference between right side and the left side. For example, our patient today, patient has a difference of 4.3 millimeters, but has no deviation. So there is the same degree of deviation that the difference between both sides. So if the answer is no, the patient is a compensated asymmetric. And what that means, that the patient has an internal asymmetry in terms of craniometric structures, but they compensate in some areas of the craniofacial area. Could be the level of the fossas, could be the anterior position of the TMJ, could be the frontal angle, the gonial angle. But the most important thing, this kind of patients was impossible to identify or diagnose without three-dimensional craniofacial diagnosis. Then we made some different measurements to know or to evaluate the symmetry between the maxilla and the mandible on an axial view. Also, here is another representation, same patient. Look, the difference in height of the right condyle and the left condyle that are compensated the difference between the right and the left side. So we are also seeing that on this triangle representation. And here we can see also another way to look at the sagittal relation between the maxilla and the mandible. What is more important that that way we avoid the limitations that other kind of measurement has as A and B or with surprisal, because this one is not influenced by any intracranial structure such anterior, posterior, or vertical position of nation, neither the inclination of the occlusal plane. We've already performed a study based on the 700 CVCT, and we found the normative value for this sagittal difference between point A and point B, but this is a paper that is under review, and hopefully I will share with you soon. And finally, we performed all the sagittal analysis, right side and left side, that you already know, as the angle of the occlusal plane, IMPA, angle of the mandibular angle, position, inclination of the incisor, interincisor angle, which is not very new. It's only applying all the concept to the three-dimensional area. We also evaluate the position of the incisors over right, over jet, the A and B, and also together with the difference, linear difference between point B, point A, Ricketts facial axis, and also lower face height and total face height, the anterior posterior evaluation of the position of the incisor and the menton. And we also evaluate all the position of the teeth in relation to the axial plane to know if there is a real canting of the occlusal plane that we should correct. We also see that, or look at that on the lateral view. We compare the inclination of the occlusal plane with the prosthetic camper plane, because we want to have a more parallel as possible the occlusal plane in relation to the prosthetic camper plane. And we also made some other measurements in relation to symmetry between the right and the left side. Also symmetry in the axial view between the right side and the left side in terms of teeth position, midline deviation. This is very important for surgeons, because we analyze the relative position of the teeth in relation to the mandible. Is for you to understand me, is if I make those measurements taking into account only the mandible in cases with real asymmetry, when we have to make a correction of the asymmetry by surgery. We need to know if those teeth on their basis, on their bone basis, are correctly positioned, or if I need to perform, for example, a distalization of all those teeth and then make the surgery. Then, of course, we analyze the transversal discrepancy evaluation. We use the measurement that Minor described in 2015, when we evaluate the skeletal difference and in a point that he describes as point S, and which is more important, the inclination, the torque, vestibular palatine torque of the teeth, to know if there is compensations, to know or to describe how the Wilson curve is. Because when we have a very, very pronounced Wilson curve, we can have contacts on the palatine cusp that are producing fulcrum. And we also can, if we don't analyze that, we can find, or we can have a conclusive relation to the transversal relation. Finally, we analyze the area analysis based also on this paper that was published by my friend and my co-director of PhD, Dr. Raquel Guijarro, together with Dr. Swen, where they describe the limits, anterior, inferior, and superior limits to generate a reliable reconstruction. And in this case, for us, it's important to evaluate, which is the measurement of the maximal constriction area, because as we know, there is no enough data to make a final diagnosis. To diagnose sleep syndrome apnea, we need to perform other kind of measurements, but it's a measurement that can give us an idea of the risk of our patient having that. We can have a risk of severe sleep apnea with less than 52 millimeters, moderated with between 52 and 110, and mild more than 110. So it's only a matter of analyzing everything that we can in our patient. And then also, of course, we have to take the advantage of having a CBCT. We perform the panoramic evaluation, the frontal evaluation, and also the lateral X-ray. So, of course, new answers need an open mind and new perspectives. For me, it's very important to understand that now we are responsible to use the technology, taking or having all the information that they can give us. So if we have a CBCT of the cranium of the patient, we need to analyze everything in terms of having the best conclusions. So bad news, we don't have all the answers yet. As I explained, we have a lot of things to do to have a conclusion in terms of those things that I was presenting today. But the good news that we promise to dedicate all of our effort to look for them. So thank you very much